Thanks, John. It's a really privilege to be here at this great meeting, which always teaches us so much about evaluation, management, and prognosis in lymphoma, myeloma, and CLL. So I'm going to focus and really drill deep in terms of optimal approaches for management of CLL patients who have deletion 17p, or for that matter, p53. I want to start at the outset by acknowledging my Mayo Clinic colleagues who are listed here who've done so much to teach me and to continue to publish about patients with 17p and p53. I also want to acknowledge my colleagues at Mayo Clinic and cytogenetics, Gordon Dewald, who I'll talk about a bit more, unfortunately passed away a few years ago, and Dan Van Dyke, and also the CLL Research Consortium, Tom Kipps and Laura Vicente, in terms of some recent FISH analysis, which I'll discuss with you, and then appreciate my funding sources within the CRC, as well as the NIH and NCI support, but most of all, the patients who provided tissue for us and follow-up that's allowed us to learn about 17p and p53. The objectives are listed here for you. They're really threefold. One is, as I said, I'm going to drill deep in terms of 17p and p53 mutations, both in terms of the structural and functional aspects and their detection and prevalence in CLL, and talk a little bit about, are they always a bad outcome? Is it somewhat like that telegram that says, stop worrying, details to follow? And also talk about management of patients with 17p and p53. I think the prior talks have been a great primer for some of the things I'll mention. I'll be able to go over them fairly quickly, but hopefully reinforce where we look at chemoimmunotherapy or novel inhibitors and their use in CLL patients. Now, I want to start out by mentioning my colleague, Dr. Gordon Dewald, who unfortunately passed away a few years ago. He was the inspiration and genius for the FISH panel we now all use. He devised the strategies and probes that were used to pick up the common recurring abnormalities, and they're shown here for you. This is a standard FISH panel, which is available pretty much nationwide, and it picks up the common recurring genetic abnormalities that can be evaluated by probes, the 6q, the trisomy 12, the 13q, 17p, and the 13q. Of course, I'm focusing on 17p in this talk. Now, just to show you a little bit more about the 17p FISH detectable defect, this is chromosome 17, and we have two probes that we use in our FISH panel. One for the p53 gene, it pretty much covers the entire p53 gene, and then a probe for the centromere, which is a repetitive DNA probe. And you can see, as an example, a normal on the right-hand side of the slide where you see 4 probes, at least I hope you can, and on the left-hand side, you see the one missing red probe indicating a 17p defect. Now, just to show you a little bit more about TP53, we can obtain this, if you will, on a routine basis now at Mayo Clinic. Some of the work that Esteban Braggio has done, as well as our own work in Rochester Mayo, has really shown us that there's a hot spot of mutation. This is the TP53 gene. You see the exons here that code for the protein, parts of the TP53, but between exons 5 and 8, it appears to be a hot spot for mutations. And this is also, by the way, true for myeloma. Now, at the bottom, what you see are the patients with p53 mutations, and where you see the bars rise higher in allelic fraction, these are probably clonal. But when it gets to about 40 or 50%, these are probably subclonal. And there is clinical impact with these subclones. And this is best illustrated by work from David Rossi, where he published a few years ago that for patients who do not have TP53, that is their wild type, their overall survivorship is much different than if they're clonal or not, or subclonal. So it's important to even know that now for CLL patients in terms of prognosis. In terms of further information about 17p, this is a very nice paper taken from Jennifer Brown's laboratory, just recently published Clinical Cancer Research, and what it is a focus of whole exome sequencing and SNP analysis along with FISH and some other techniques to look at karyotype. And what the major findings are shown here at the bottom, where for patients for 17p in terms of overall survivorship, clonal TP53 mutations, having 3p, 4p, or 9p deletions, and genomic complexity is associated with a worse outcome in terms of OS. If it's subclonal in the second allele, or there are no mutations and lack of genomic complexity, it looks like these patients actually may fare better. So why are these defects bad for CLL patients? First of all, it's important to be aware that for most patients, if they have a FISH detectable defect, they're probably going to have a TP53 locus abnormality. And if it's not right away, it'll be sometime during the course of their disease. These deletions and mutations disrupt P53, and just to be very cryptic about this, an intact P53 pathway is critical for mediating cell death, for example, after exposure to DNA damaging agents. So in terms of the demographics of 17p, for untreated patients, we see abnormalities in FISH by 5 to 10% of patients who are going on to first-line therapy. Obviously, you've heard a lot about the poor outcome of patients with 17p. It's been observed for over 20 years, and it's been found in multiple prospective trials. The median overall survivorship in many phase 2 and phase 3 trials appears to be around 2 to 3 years from the start of chemoimmunotherapy. And as you've heard, you very rarely get a CR with CIT. And what about treated patients? Unfortunately, there appears to be a selective pressure, and now the incidence of 17p and the P53 mutation detection is up to around 23 to 44%. No one understands completely the biology of this, but it may be that subclones are present that expand, or that new mutations occur through the selection pressure of CIT and the overgrowth of these subclones. Now, not all patients with 17p or P53 have bad outcome. There are indolent patients. We have developed in concert with the MD Anderson group a model where you can use risk factors listed here, RISE stage 1, unmutated IGVH, and 17p greater than 25% of the nucleated red cells. Here you see a figure from our paper published a few years ago, where as the clone size goes up in terms of detectable 17p, the survivorship is worse. And if you use these three parameters I just mentioned, you can subdivide patients into three risk models, three cohorts, and you can see the 3-year survivor rate is very different depending on where the patient fits. Now that's one model. There is an alternative model developed by Bill Weirda and the Ohio State group called the simplified risk score. I thought ours was pretty simple, but they think theirs is simpler. And basically here you use the ECOG status, greater age over 65, and a high LDH. This can identify very high-risk patients who have 17p, and probably you might want to consider putting these folks on clinical trials if they're available. But they also indicate, and I agree with them, that you could identify low-risk 17p that could be followed. So what about FISH testing in CLL in relationship to 17p if you do not have access to sequencing and to other testing? So we started a study with Laura Rosenti and Tom Kipps, which was a CRC, CLL Research Consortium study. 6 different sites contributed patients for this study, and we studied almost 1,600 patients. And we essentially were looking to see if we could update the Donner study, which was published in 1999. And this study established this well-known hierarchy shown here of favorable to unfavorable outcome. And we looked at the FISH data in this consortium in terms of time to first treatment and overall survivorship. And the major findings are shown here. 17p deletion had the poorest median overall survivorship, so it's still worst in terms of OS. However, again, the clone size was shown to be associated with time to first treatment. I'll show you that. And then, interestingly, the most rapid time to first treatment hierarchy was actually now 11q and then 17p. This is just a figure from the paper showing that if patients had less than 70% 17p, they didn't do so badly. But when they got up to 50% plus, they did much worse in terms of time to first treatment. So what about an approach to asymptomatic early stage CLL with deletion 17p and p53? Right now, we would propose that patients with deletion 17p should have additional prognostic workup. Very important to know if they're unmutated or mutated. If available, a stimulated karyotype does appear to be important in adding worse outcome for patients with 17p. And I don't have time to go over this, but there is now a CLIPI, a CLIPI, where you can use 5 different variables to get a number, an actual number that tells you the risk of your patient, even in early stage of progression. And they're fairly easy to use, at least if you have access to TP53, IGVH, and of course beta-2, rise stage, and age. In terms of monitoring these patients, remember, no need for therapy if asymptomatic, unless, of course, they're high risk and you want to put them on a clinical trial. We do advocate potentially having a discussion about allogeneic stem cell transplant. So let's turn the last half of my talk to what about progressive CLL? What do you do with these patients if they're progging and they have these defects? And a lot of the data that I'm going to present to you is covered, so I can go through it quickly, but hopefully emphasize some of the key points. So this is just a case for illustration. 69-year-old man who has a cold, he's got palpable spleen, high white count, is a little anemic, little thrombocytopenic. He's got flow that's consistent with CLL, and I emphasize that because not all patients have absolutely the gold standard phenotype, so we need to be sure of that. And unfortunately for him, he has 98% of his cells abnormal by FISH. He comes back 10 months later with a pretty dramatic change, 20-pound weight loss, splenomegaly, tripled the white count, more anemic, and now the platelet count's less than 90,000. So this isn't a question you have to flip a button on, but I just want you to think about this. Would you observe, would you give CIT, FCR, BR, single agent OFA, Idela, Ritux, Ibrutinib, venetoclax, or are you not sure? So really the debate here, maybe not much of a debate, but I think room for discussion is CIT versus novel agents. And I would propose, of course, having seen the history of this, as several others in the room have, that CIT era was up until about 2009. And then Rick Furman and others started testing signal inhibitors, and it's changed a lot. So we can't recommend CIT for all patients, but what's the case for novel agents, and where do they fit with CIT? And then the other question we need to talk about briefly is how do these inhibitors fit with reduced intensity allo? So just to show you one trial I don't think has been shown is a CLL4 trial, which compared F to FC, fludarabine-based therapy, and you can see that in this trial reported several years ago, if you don't have 17p, you do pretty well, but if you have TP53 mutation or 17p, you don't do well with a fludarabine-based regimen. Now, the pivotal trial you've heard about earlier from Bruce Chesson, the CLL8 trial, where it's FC versus FCR. What's interesting in terms of the analysis here was that for FC or FCR, if the patient had a TP53 mutation, they did not do well, whereas they did much better if they were wild type. So what are the targets that have changed the 17p p53 therapy game? Clearly, downstream of BCR pathway, the BTK molecule inhibition and the PI3 kinase delta inhibition, and the targeting BCL2 by venetoclax has turned out to be crucial in advancing our therapy. And just to briefly review in more of a schematic here, that simply put, we believe that that venetoclax is primarily working by displacing BIM and then allowing BIM to interact with BAX and BAC and then induce mitochondrial depolarization and apoptosis. So just to remind you, the phase 2 Ibrutinib monotherapy trial, here you see the total numbers of patients in terms of their response, 90%, mostly PRs, but some CRs, but even deletion 17p. Lots of PRs, but a few CRs. So that was very encouraging. At the 3-year follow-up, and we're going to hear more at ASH, as you've heard from Stephen Coutret's comments, the PFS looked quite good for this group of patients, really almost unheard of. Maybe there's a bit of a tail for 17p patients in terms of PFS, but in terms of OS, at least the current data suggests that the median has not yet been reached. In the RESONATE phase 3 trial, looking at Ibrutinib versus OFA, just to illustrate again in terms of 17p, Ibrutinib clearly a winner over OFA, and that was inclusive of 17p patients. Been some updates on 17P and Ibrutinib to keep you up to snuff here in terms of what's out there right now. The NIH group, the Faroki group, the Adrian Wiesner group has published in 51 patients that were treated and untreated. There was a 97, 80%, and 80% overall response rate for 17P patients. These were PRs and PRLs. With the Resonate 17 trial reported by Susan O'Brien, which is 145 patients, a phase 2 multi-center trial, there was a 64% overall response. And I think very impressively, Jeff Jones published or presented at EHA a multi-clinical trial analysis of 243 patients, all 17P. And this is a quote from his talk: "The estimated median PFS and 30-month OS for Ibrutinib surpasses those of other therapies for deletion 17P. In terms of rituximab idelalisib, you've seen this earlier. Clearly, rituximab is superior to the placebo plus rituximab. But in terms of drilling down on the focus of my talk, you see that for mutated and unmutated, the Ritux is equally effective, and also equally effective for mutated versus not present. In terms of OS, again, all patients benefit from having Ritux. The unmutated do better, perhaps deletion 11q, but again, the deletion 17p, p53 do better. What about venetoclax monotherapy? You heard a very nice talk by Rick Furman really detailing this. Just to illustrate, again, some of the things I think that are impressive about this is that the response time to venetoclax was very quick, and MRD could be reached in these patients, and the 1-year PFS estimated to be 72%. So that's certainly a major advance. So going back to this patient, again, thinking out loud, I can sort of see what you're thinking in your mind. What would you do? Would you observe, give this patient CIT, ofatumumab, Ritux, Ibrutinib, venetoclax, or unsure? I'm sure you have a more firm opinion about that now. But here's what is a constellation. This is my take on the current situation. For patients who are less than 70 who meet the criteria for treatment, we divide them into fit and frail. And if they're fit, do they have 17p or do they not? If they do not, we definitely still think of clinical trials or chemoimmunotherapy, definitely on our radar screen. If they have 17p or p53, we're thinking clinical trial. Ibrutinib would certainly be right up there. And then other options are methylprednisolone and rituximab. If they're fit, we should be at least thinking about transplant down the road. And if they're frail and don't have 17p, as Bruce Jessen mentioned, some really attractive options, chlorambucil and obinna, or even methylprednisolone and rituximab could be considered. But if they do have the 17p defect, you can go down this middle box, except you wouldn't go to the transplant very likely. In terms of relapse refractory patients, I think one point that's very important to emphasize is if they're post-CIT and they're symptomatic and they have not had a FISH test, you need to repeat it. Even if they have had it, you need to repeat it, because these patients are at much higher risk for progression to develop 17p or p53. And then if they have it, this would be our constellation, where it would be BTK, Ritux, and venetoclax. Now, if they're post-BTK, I think these two options are available for you, Ritux or venetoclax, and I think that maybe Steve Coutre mentioned this. One study published by Jeff shows that overall response rates can be obtained with venetoclax of 61 and 50% following BTK Idela. And then, of course, the CAR T-cell approach, ultimately, we need to be testing that in this high-risk group. Now, one last slide before I summarize. So basically, the big question is, for the high-risk patient, do you want to go to transplant ultimately, or do you want to use a signal inhibitor, given the excitement and the very effective response rates we see? To my mind, we need to have randomized comparative clinical trials. Comparing those two, those are never going to happen, just the way it is in our country and actually probably internationally. So we need to really think about the clinical situation for this patient, the expectations of the patient. And I like this figure, which is taken from a publication by Emilia Montserrat and Peter Drager, which is really a consensus from the EBMT and the ERIC groups, which really says if you have a relapsed or progressing patient who has 17p and they're on a BCR inhibitor, If they're responding, continue. If they're not, think of transplant. But I think critically you need to know whether they fit the mode for a transplant or not. For patients who have no response to a signal inhibitor, you can think of transplant again, but they hopefully have factors that favor transplant, or look for an alternative inhibitor. So in summary, not all CLL patients with 17p defects have very aggressive courses. There is insight into why. It may include that risk is based on clone size and when in the disease course the 17p defect is found, but more research needs to be done on that. For aggressive CLL patients, as you've heard now, I'm sure, a few times, with 17p or p53, they're less likely to do well with CIT. And clearly the novel inhibitors are effective, but we need to enhance the CR rates and MRD negative status for these high-risk patients. Thank you very much.